Alrighty, hello class. So I am going to pre-record this lecture for you guys. It's found under week 2. It's central, peripheral, and cerebral arterial anatomy. So I'm just going to record this lecture for you guys to view on your own time. Hope you guys all have a safe, happy, and healthy holiday weekend. Over here at Riverside, it is super hot. We put in a work order for the air conditioner again, so hopefully we can get this rectified sooner rather than later. I apologize to all you guys who are sticking it out on Tuesday, sweating it out, but hopefully this is going to get fixed fairly soon. Anyway, so you guys can feel free to message me with any questions that you have regarding this lecture. Basically, this is going to be a lot of anatomy review. So these first couple PowerPoints, or the next couple of PowerPoints, are going to really kind of dive into a lot of vascular anatomy. So if you're really strong in A&P, you memorized your blood vessels, you should do well in this for these next couple chapters. Sorry. So this is a general schematic or overview of our arterial circulatory system within the body, showing all the major blood vessels as they arise from the heart. So our systemic arterial circulation begins at the heart with our ascending aorta, and everything kind of branches from there. So we're going to talk about central and peripheral arterial anatomy, as well as some cerebrovascular anatomy. So when we're talking specifically about central arterial anatomy, we're talking mainly the abdominal aorta. In terms of imaging the aorta, in vascular, we focus on the abdominal aorta because that's what we're able to see and image in the realm of vascular sonography. Us being echo techs as well, we could see and assess the thoracic aorta in the chest. But if I was to take, my vascular probe and try and image the thoracic aorta, it's just not going to work. So as echo, we can assess segments of that thoracic aorta, particularly the ascending aorta, aortic arch, and then a portion of that descending thoracic aorta. But specifically, when we're talking about central anatomy in terms of vascular, we focus on the abdominal aorta. When we're referring to the abdominal aorta, there are several major branches which arise off that abdominal aorta. So if we're working our way from superior to inferior, going from the head down, we have our abdominal aorta. The major branches which arise off that abdominal aorta. The first one is going to be our celiac artery. Our celiac artery. This is the abdominal aorta. I'm just going to kind of draw the diaphragm here. So just remember that diaphragm is what separates our abdominal cavity from our thoracic cavity. So our first major branch is going to be our celiac artery. Shortly beyond or shortly below the level of the celiac artery, we have our superior mesenteric artery. So both of those again arise off the anterior aorta. Below the SMA, we have our renal arteries, right and left renal arteries, bringing blood flow out to the kidneys. And then below the level of the renal arteries, we have another vessel coming off the anterior aorta, which is our inferior mesenteric artery. We do have some other vasculature which exists, particularly when we're talking about the liver. When we're talking specifically about the liver, we have hepatic arteries, which bring blood flow to the liver. The hepatic arteries, or the hepatic artery, is one of the branches off of the celiac artery. We also have portal veins, The main portal vein brings blood flow to the liver as well. So both hepatic artery and portal vein bringing blood flow to the liver. The portal vein drains blood from the mesentery, from the bowels. And we also have the hepatic veins. So the hepatic veins actually drain the liver. So they empty blood flow out of the liver and can join into the inferior vena cava. So talking specifically about the abdominal aorta, this is the major supply of blood to the digestive organs, kidneys, adrenal glands, gonads, abdomen, abdominal and perispinal musculature, the pelvis, as well as the lower extremities. So this brings blood flow basically, to all the organs of the abdomen, to the digestive tract, so the intestines, small intestine, large intestine, bowel, rectum, any pelvic organs, so things like the ovaries, the gonads, testicles, as well as perfusing all the way down the lower extremities, so supplying blood flow to the legs and feet as well. When we talk about the lie of the aorta, so it lies just to the left of midline. So if I'm looking at the patient, the abdominal aorta is going to lie just to the patient's left of midline. IVC courses to the right of midline. So aorta to the left, IVC to the right. It starts larger in diameter and will start to taper and get a little slightly more narrow distally as we work our way down. And then aorta will typically bifurcate or split into the right and left common iliac arteries at the level of the L4 spine. So this is typically around the level of the umbilicus, the belly button. So when we talk about normal diameters, we like to use 3 centimeters as our measurement of determining, whether an aorta is considered dilated or aneurysmal versus versus a normal diameter. So when we look at that proximal aorta, we said it's larger more proximally. So typically has a maximum diameter or normal maximum diameter of 3 centimeters. Middle and distal segments should be less than 2.5 centimeters. And then the aortic bifurcation, so both of those common iliac arteries should measure less than 1.5 centimeters. So when we're talking about aneurysmal aorta, if we see a measurement greater than 3 centimeters within that aorta, we consider that aneurysmal. And when we're talking about the iliac arteries, we could potentially also have aneurysm of those iliac arteries. If we get a diameter measurement greater than 1.5 centimeters, we can consider that aneurysmal as well. Draw a little bifurcation. So this is a nice little schematic or nice little drawing showing here, first off, our diaphragm, and then the aorta passing through an opening in the diaphragm, and then our proximal aorta, and then our celiac axis. And you can see the branches of the celiac axis. We have our hepatic artery, left gastric artery, and our splenic artery. So celiac axis or celiac artery. So those two names can be used interchangeable. Some places you might see it described as celiac axis. Some places you might hear them say celiac artery. So those are both the same thing. They're both the same term. So that refers to that short segment of the artery actually coming off the aorta, or like before it starts to branch and split into those 3 individual arteries that perfuse out to the spleen, to the liver, and then to the stomach. As we work more inferior down the aorta, we then have the SMA, followed by the renal arteries, a little slightly more inferior to that SMA. And then further down the aorta, we have the inferior mesenteric artery, also arising off the anterior aspect of the aorta. So celiac artery, SMA, and IMA all arise off the anterior aspect of that aorta, so kind of coming forward off that anterior aorta. right and left renal arteries arise from both the lateral aspects of the aorta. So this is just a sonographic image now showing a normal abdominal aorta. So this first view over here is the sagittal or longitudinal plane. So up here we can see a portion of the liver as it courses posterior to the liver. This looks like the left lobe of the liver here. So we can visualize one of the first branches of the abdominal aorta. So this is probably the superior mesenteric artery, just in the way it's curving. So it's arising and kind of running downward and paralleling that aorta. This is probably celiac artery that we're seeing a little piece of it. And now this is a transverse view. So you can kind of also appreciate one of the things here too is how close this is in proximity to the actual spine. So how deep it is in relation to that patient's spine. So this is probably this is going to be most likely a more proximal segment. So that's another thing too, as well as tapering distally. The aorta also tends to run more anteriorly as you go down. So it's deeper higher up and kind of runs more closer up towards the surface, or more anterior, closer to the surface of the body or surface of the skin as we move more distally as you move down. So those mid and distal segments, are oftentimes a little bit easier to image, unless of course the patient's got a big, huge gut, and then, all bets are off. But you can also see the relationship of the aorta to the IVC. So if you just kind of visualize yourself, scanning in transverse, you have your patient lying there on the table, your camera's in that transverse view with the notch, pointing towards you. So this side of the screen is going to be our notch. So it's pointing to the patient's right side. So we can see the IVC is on the right, aorta on the left. So that's just something you're always going to have to get accustomed to, always keep it in your mind and your head when you're imaging, aorta to the left, IVC to the right. It's just angling to the left, aorta, IVC to the right. So if you can see, what looks like the IVC, you have to angle to the left to get aorta. If you see aorta, angling to the left, to get IVC, you got to angle to the right. So these are some Doppler waveforms, normal spectral Doppler waveforms for our abdominal aorta. So these are, you can notice, slightly different. They look pretty similar, but they both have some slight differences to them. The first one is taken above the level of the renal arteries. And so you can see that one is a little more, has a lower resistance to it. When we were talking about that RIs last week, that resistive indices. So this has more diastolic flow. So that's indicative of less peripheral resistance. So this is going to have a lower RI. Whereas something like this has a much higher RI. You can see that this one's actually triphasic. So they measured an end diastolic velocity of 17, whereas this one had an end diastolic velocity of 32. So if you put those numbers into your equation, you can get you can tell that this one has a much lower resistive indice. So the reason for that being, remember we said that arteries get their characteristics or their Doppler characteristics based on where they're going. So at this point, we're sampling higher up in the aorta. So some of that blood flow is going to organs. Remember we said that organ flow has low resistance and needs that constant forward flow. So up here, we have some of that aorta blood going into, the celiac artery to the liver, which is an organ, going from the celiac artery into the spleen, an organ, going to the stomach, an organ as well. Some of that blood flow is then also perfusing to the kidneys. So it has some of those characteristics of, the renal arteries, the hepatic arteries, the splenic arteries. So we got blood flow that's going to the organs at that point. Once we drop below that level of those renal arteries, the really only branch we have left is the SMA. And then the rest of that blood flow is going down the legs, going to some of the, going down the aorta into the iliacs. And then the iliacs will either go down to the legs, which is, conserve peripheral vascular flow, going to have high resistance, or it's also going to some of those distal portions of our intestine, and which really essentially don't necessarily need that much blood flow compared to, our vital organs. So that typically has a higher resistance or higher resistant vascular beds than some of these organs that the aorta blood needs to feed when you're higher up. So that's why you could see these changes, or the slight changes, in the resistive indices based on whether you're above the renal arteries or below the renal arteries. So these are the major, again, abdominal aortic branches that we were talking about. So the celiac artery, or the celiac trunk, or the celiac axis, all this mean the same thing, can be used interchangeable. This is the most cephalid, meaning cephalid towards the head. Caudal is downward. So this is the most superior branch of the abdominal aorta. Again, we said it arises off that anterior aortic surface. So this artery will trifurcate, so have 3 branches, and those 3 branches are the common hepatic, splenic artery, and then the left gastric artery. So when we're imaging this, we can best see this in our transverse plane or transverse orientation, and this will form what looks kind of like a T, or you might even hear it referred to as a seagull sign or a seagull configuration. So it kind of looks like the wings of a seagull kind of branching off. And the waveform characteristics, or the Doppler characteristics of the celiac artery, are going to be a low resistant waveform. Again, we said, these waveforms get their characteristics based on where that blood flow is going. So this is just again a picture showing we're in transverse now. We see the aorta as a circle. That's celiac artery or celiac trunk or axis coming off the abdominal aorta, and then the branching of that vessel. So when we see that seagull, the 2 wings of the seagull, or the 2 branches of that T, the one going to the left is the splenic artery. So this is actually a little piece of splenic vein. So splenic artery, and then the common hepatic artery going towards the patient's right. So liver's on the patient's right, spleen is on the patient's left. And you can see the Doppler characteristics of this waveform. We could see, quite a bit of diastolic flow. So we know that this is a nice low resistant waveform. So continuous forward flow, monophasic. Talking specifically about the SMA. So this supplies blood flow to I think of it as like, the proximal intestines, or the proximal gut. So it supplies blood flow to the jejunum, the ileum, the cecum. So I think of like all the organs, all the parts of our digestive tract, the colon and the intestine on the right side of the body, the parts of the transverse colon, so the proximal 2/3 of that transverse colon, the duodenum, so the beginning of that small intestine, as well as blood flow to the pancreatic head. So you can easily identify it in both longitudinal and in transverse planes. SMA is one of the arteries that's also very distinguishable. So you can tell the SMA right away from any of the other arteries because it has a distinctive triangular mantle of fat that surrounds it. So it looks like it has this very bright echogenic, like almost like donut or circle surrounding that artery. So it makes it very distinctive and easy to identify. When we're in the sagittal view, we can actually see that SMA will kind of course along the same path as the aorta. So when we're in sagittal, we could see our SMA. I'll come off. So aorta, this is our aorta and sagittal. Blood flow is headed, from the heart going down towards the legs in that direction. So the SMA will take off, and you'd be able to see it kind of rising off and then kind of coursing more anterior along that course of the aorta. Transverse, it's very recognizable too as well. So the pancreas, a couple landmarks too. The pancreas and the splenic vein will lie anterior to the SMA. The renal vein, left renal vein, will lie posterior. Sometimes you can identify turbulent flow near the origin of the aorta. So since this vessel is supplying the majority of our digestive tract in terms of the intestines and bowel, it will have differences in flow characteristics based on whether the patient is fasting or not. So that's a unique characteristic of the SMA. So if the patient is preprandial, so if they're MPO, they haven't eaten in a long time, if they've been fasting, the SMA is going to have a high resistance. So you'll be able to document a high resistant waveform in that SMA. The reason being is, the patient's fasting, they're not digesting any food. So there's no real need for blood flow to go to the intestines to aid in digestion. So that blood flow is going to, the resistance of that blood flow is going to be high because there's no need for blood flow to go to those particular organs to aid in digestion. But if the patient's eating and they're digesting food, fruits working its way through their digestive tract, there's the need now for that blood flow. The resistance of that waveform is now going to change. So the SMA has the ability to go from high resistance to low resistance based on whether or not that patient is fasting or not. So this fact becomes very critical and very important when doctors are trying to rule out something called mesenteric ischemia. So there could be patients where the bowel, the mesentery, isn't receiving enough or adequate blood flow, and that bowel could start becoming ischemic, necrotic, start rotting as a result of blockages and stenoses within the SMA or IMA. So we look for changes, in those resistive indices. We do a baseline study with them fasting. This is what it is. After they eat, we check to see if we get reversal of that resistance into something that is low resistance. So it's important and critical, if they want us to really assess the SMA, that, that patients truly are fasting. They've been MPO for a substantial period of time. We usually MPO them overnight, so it's at least 8 to 12 hours. And then we can get an accurate study. So we image them fasting, then we image them after they've, consumed some sort of caloric intake, and they're in the process of digesting that food to look for this flow resistant changes. So these are some good images now, so you can actually really appreciate, particularly this first one, or your transverse view of the SMA, and you can see how you get this very echogenic ring around the vessel itself. Once we get in the lab and start scanning a little bit more with ultrasound, when you guys start doing intro to patient care and she has you scanning an aorta, see if you can identify, SMA when you're in transverse, you'll be able to, it'll be very, very recognizable to you guys. And then in sagittal view, when we see our aorta in long, our first branch being our celiac artery, and then the SMA arising, that's the next branch arising off the aorta just below that. And you can see it coming off and then kind of paralleling the aorta more anteriorly. So this just shows the changes in those Doppler signals that can be seen, whether if the patient's fasting or not. So you could see preprandially when they're fasting, you get a triphasic high resistant waveform, and then low resistant waveform after they've eaten, or postprandially. It's another example showing a fasting SMA. They have a resistive indice of 0.84. All right, renal arteries. So renal arteries, these are going to rise from the aorta slightly below the level or the origin of the SMA. So it's typically about 2 centimeters below the level of the SMA where the renal arteries come off of. So when we're in sagittal view, trying to visualize the aorta, we can't really see the renal arteries coming off in our true sagittal view when we're kind of midline, because those renal arteries are coming off to either side. So just remember, ultrasound is just a slice. It's just a single cross-sectional slice. So if we're slicing through the middle of that aorta, we're not seeing what's going off to the sides of the aorta. We're just kind of imaging right down that middle of the aorta at the widest section. So celiac artery, SMA, they're rising off that anterior aorta. So we could see that as we're slicing through that SMA with the aorta behind it. So we're able to see those branches, SMA, IMA, celiac. But the renal arteries, we can't really visualize. We're not going to be able to visualize in a true sagittal view of the aorta because they're just arising laterally. And maybe if we angled a little bit to the side, potentially we could pick up a little piece of one of the renal arteries. But to visualize the renal arteries, we now need to be in transverse at the level of the renal arteries. So then we could see, to the right and to the left of the aorta. So just remember that those renal arteries are about 1 to 2 centimeters below the level of the SMA. Just going to kind of go back a little bit, actually, also to just kind of discuss just one more thing. So when you're imaging aorta as well, we break it up into segments. So you can't image the whole entire aorta in one shot. It's just way too long, way too large. So we break it up into proximal, mid, and distal segments. Just some of the landmarks that you like to use or we use when we're referring to proximal, mid, and distal aorta. The segment of the aorta that's above the level of the celiac axis or the celiac artery, we consider proximal. So if we want to image proximal aorta, proximal abdominal aorta, we're referring to the segment that is above the level of the celiac. So this is our celiac, SMA. I'm just going to kind of pencil in renal arteries here. And then IMA lower down. So proximal aorta is referred to the area that's above the level of the celiac artery. When we're talking about mid aorta, typically they refer to mid aorta when you have to Doppler or take measurements. It's at the level of those renal arteries. So you can't really, see them on our longitudinal view or sagittal view. So I kind of just, if I was to measure a Doppler, I would go, just below the level of that SMA, about 1 to 2 centimeters. And that's where I would place my caliper. If I had to take a velocity measurement or do a caliper measurement, I would measure just below the level of SMA is considered the segment or true mid segment of the abdominal aorta. So really, in theory, mid segment will be anywhere from the celiac to just below the level of the renal arteries. So that constitutes a good mid segment. And then distal segment could be anywhere from just above the IMA to just below the level of the bifurcation. Not just below, just above the level of the bifurcation. I apologize. So distal aorta, around the level of the IMA up to where we get the bifurcation. So anywhere in there would be considered distal abdominal aorta. proximal abdominal aorta above the level of the celiac. Mid aorta is technically around the level of the renal arteries, and distal aorta would be, the area from the bifurcation up towards the IMA. I apologize. So going back to the renal arteries, the right renal artery arises from the anterolateral, so slightly anterior, but still the lateral aspect of the aorta. Closer is posterior to the IVC and is longer than the left renal artery. Kind of throw my IVC in here as well. Kidneys. So I know a lot of questions when we get to the registry and to the boards, they like to focus on the renal arteries. On a lot of the basic anatomy questions, you can kind of just think about and figure out logically, if you just kind of think about the human body, think about the organs, where they are in relation to each other, and where those vessels have to go. So that first statement, of course, is posterior to the IVC. That's something that you're going to soon come to realize, and you're going to have the image in your head as well, the transverse image of all this as well. So I drew it coursing posterior behind the IVC, and it's longer than the left renal artery. So if you just kind of think about that logically, aorta is on the left side of the body, it's left of midline. So that left renal artery doesn't have as far to go to get to the left kidneys on the left side of the body already. Whereas the right renal artery, has to cross midline, pass under the IVC to get to that right kidney. So it's got a longer distance to travel. So just logically, based on the fact that the aorta is on the left side of the body, the left renal artery is going to be shorter than the right renal artery. Left renal artery arises lateral or slightly posterolateral aspect of the aorta. Courses posterior to the body of the pancreas and the splenic vein. The main renal arteries have branches once they get into the kidneys. So we have one main renal artery going to each kidney. Those renal arteries then branch once they get into the kidneys, into the segmental arteries. The segmental arteries branch into the interlobar arteries, which then branch further into the arcuate and then into the interlobular arteries. So when we get into third semester vascular and we're doing abdominal vasculature, we're going to really focus more on the kidneys and really learn all these segments. Main characteristics of our renal arteries are that they're very low resistant. So the kidneys are always in need of blood. We always want that forward flow. Just realize there could be anatomical variance. So we're going to learn very quickly in vascular, anatomical variants always exist. So just because you're used to seeing something one way doesn't necessarily mean it's going to be that way. So this just shows, again, right renal artery coursing posterior to the IVC, left renal artery, not as long. So this, again, now we see a transverse view here. So this is aorta, IVC. So we can see left renal artery, left renal vein. So the artery coursing posterior or behind the left renal vein. Same thing on this side. You can see aorta now, the right renal artery coursing posterior to the IVC and posterior to the right renal vein going into that right kidney here. So this diagram just shows some of the renal branching that we were mentioning before. Main renal artery branching into the segmental arteries. The segmentals then branch further into these interlobar arteries. So we have segmental, then the interlobar. The interlobar arteries then become, so segmental, these are your interlobar arteries. The interlobar arteries then become these smaller arcuate arteries that feed the cortex of the kidney. So this is where a lot of that filtration goes on within these arcuate and the interlobular arteries. So then the smaller arteries along the peripheral are your interlobular. So these are some normal waveforms for both the renal artery and the renal vein. So we could see a nice low resistant waveform with forward continuous flow throughout the diastole. This is an example of a patient that has multiple renal arteries here. So we could see what looks like 1, 2, 3 renal arteries actually connecting to this kidney. So when we get into third semester, when we're doing abdominal vasculature, and we're talking more specific about renal artery Dopplers, so this could actually be something that's pretty common, particularly with transplant patients. So when you're scanning a transplant kidney, some of the surgeons like to put in multiple renal arteries to supply blood flow to that transplant kidney, connecting to the iliac artery, but we'll get into that later on in the course. So just be cognizant that there could be anatomical variants that do exist. So yes, there very well could be 2 main renal arteries or even three main renal arteries bringing blood flow to the kidney. And then the final major branch for the abdominal aorta is the inferior mesenteric artery, or IMA. So this lies midway between the renal arteries and the aortic bifurcation. So the IMA supplies the blood flow to the remainder of our digestive tract, or the distal colon, as well as the proximal rectum. So we locate for the vessel heading obliquely and anterolaterally to the left between the renal arteries and the aortic bifurcation. So what that means is it's going to arise anteriorly and a little slightly laterally to the left. So if we're in transverse, it's easier to find this vessel in transverse and try and turn on it. So when you get down, to the level of around the SMA, when you're in transverse, you'll be able to see a small little circle anterior to the aorta and slightly to the left. You can recognize that as the IMA, and then you can try and turn on that sagittal and try and connect it back to the aorta itself. So similar to the SMA, this also can have changes in flow patterns as well, if the patient's fasting versus non-fasting. So same rules apply: high resistance if they're fasting, and could potentially be low resistance when they're non-fasting. So here you go. You can see this is a transverse view. So this large one's IVC. Here's your aorta. So you can see that small circle anterior to the left being the inferior mesenteric artery. So you can try and either slide up and see where this eventually connects into the aorta, or try and turn on that, elongate, and see if you could track it back to its origin with the aorta. So this shows a normal high resistant Doppler signal of a IMA in a fasting patient. IVC and aorta, just the relationship between the two side by side. And just a little cross-sectional anatomy for the descending aorta. So if we have the patient lying on their back, here you can see liver, portion of the stomach, colic flexure. So you could see liver's on the right, IVC on the right, descending aorta on the left. Just kind of moving down a little bit on a cross-sectional slice. So now you can see inferior vena cava. Now you can see the celiac trunk starting to come off. Portion of the kidneys. Down a little further now, we could see aorta again, the SMA branching off again anteriorly. So here now we can see at the level of the renal arteries, we see aorta with the right renal artery coming off. Here's our inferior vena cava, so coursing again posterior to that inferior vena cava. Aorta, left renal artery, coursing posterior to the left renal vein, so it's located behind the left renal vein towards the kidney. So this is getting down towards the aortic bifurcation now. So here we can see inferior vena cava, aorta starting to split. So you can see we have right near that bifurcation where we're branching into the right common iliac and the left common iliac artery there. Coming down a little more inferior now that aorta is bifurcated completely into right common iliac and left common iliac. Just something to note, the IVC still has not bifurcated yet. So just to know that aorta bifurcates more superior to the IVC. So if you kind of look at this cross-sectional slice here, we can see we're starting to bifurcate. IVC is still a single vessel coming down a little more. Now we've completely bifurcated the aorta, but the IVC hasn't yet. And now as we come down further, we have bifurcation of both the IVC into the iliac, common iliac veins and then common iliac arteries. All right, so some of the abdominal arteries now. Liver vasculature. So when we talk about liver vasculature, important fact to know is that the liver has a dual blood supply. So there are two vessels that are responsible for bringing blood flow to the liver itself. Liver blood flow, the blood supply to the liver comes via the hepatic artery and the portal vein, the main portal vein. The majority of the blood flow that is being brought to the liver is through that main portal vein. So the hepatic artery supplies oxygen-rich blood, about 20%, and it constitutes about 20% of the liver blood supply. The hepatic artery, so the hepatic artery arises, or the common hepatic artery splits into the gastroduodenal artery and then the proper hepatic artery. So we have the common hepatic artery that branch off the celiac. That common hepatic artery then will split and bifurcate into our GDA or gastroduodenal artery, and then the proper hepatic artery, which continues on to the liver. This hepatic artery is very low resistant, has a pulsatile flow, and is something called hepatopedal. So we're going to learn in a moment difference between hepatopedal versus hepatofugal. So pedal refers to that blood flow flowing towards the liver, into the liver. We can have blood flow that's hepatofugal, leaving the liver. So pedal is towards the liver, fugal means away from the liver. This is particularly important when we're assessing the main portal vein. Again, when we get further into our didactic classes and we start learning about conditions called portal hypertension, we can get reversal of flow within this main portal vein, and we look for hepatofugal flow versus normal hepatopedal flow. So with the portal vein, this is supplies nutrient-rich blood from the digestive system. So this vein is draining our digestive system. So, you know, we eat food, we digest food, we're processing it, and then all that food that we're eating and digesting gets that blood flow, you know, gets absorbed into or those nutrients get absorbed into the intestines, and that blood flow then gets drained to the liver for processing. So that's where the liver does, you know, the processing of all the stuff that we ingest. So 80% of that blood flow, the vast majority of blood flow that is going to the liver is supplied by that main portal vein. The main portal vein is formed by the junction of the splenic vein and the superior mesenteric vein. So we have a vein coming from the spleen, draining the spleen, and then that superior mesenteric vein, which is draining the digestive tract. Those segments of the proximal segments of the digestive tract coming together. So those two come together near the head of the pancreas in an area called the portosplenal confluence. So those two vessels come together, form the main portal vein, which then courses to the liver. Blood flow within this main portal vein is what's called monophasic. Should have a low velocity to it. This flow is hepatopedal, going towards the liver again. And then also to note that this flow will increase postprandially. So as you can imagine, after the patient's eaten, they're digesting food. So we have increased blood flow going to those intestines to help aid in digestion. So that increased blood flow going there has to also exit as well. So we have increased exit of blood flow coming from the digestive tract into that portal vein. So here we can see our celiac artery branching into the common hepatic. That common hepatic then branches into the gastroduodenal and then the proper hepatic. This is just an image showing hepatic artery as it near the porta hepatis. So the porta hepatis is an area that we refer to as where the vessels and the bile ducts are entering or exiting the liver. So bile is exiting the liver at the porta hepatis through the common bile duct. And then blood flow is entering the liver via the hepatic artery and the portal vein at the level of the porta hepatis or at the porta hepatis. So this shows a typical waveform for a hepatic artery. So a nice low resistant waveform, nice continuous forward flow, a good amount of diastolic flow. And then this shows portal vein anatomy now. So just become again familiar with your diagrams, know your anatomy. So here we could see the splenic vein. So this is coming from, here we go, we can see over here the spleen on the patient's left, splenic vein draining the spleen. The inferior mesenteric vein will also come up and connect with that splenic vein. So we have this, you know, draining those distal 2/3 of the descending colon as well as the rectum. So draining blood flow from those areas. The much larger superior mesenteric vein coursing upwards, draining the proximal portion of our intestines. So the splenic vein and superior mesenteric vein come together, form the common main portal vein, I apologize, coursing into the liver at the porta hepatis. And then within the liver, we then have branching into the left portal vein and right portal vein. So we get bifurcation once we're into the liver of that main portal vein. So again, once we get into scanning our abdominal ultrasound or abdominal sonography, so this is going to be one of the things that we're going to be imaging in our third semester class is our Splenic Vein SMV, or superior mesenteric vein, and Splenic Vein. So this is our transverse view. So you can see aorta down here. So this is, again, our SMA. You can distinguish it, by that echogenic ring around the vessel itself. Looks almost like, a thick donut around that, around the vessel. So this is blood flow in that splenic vein, coursing from the spleen and then connecting into the portal vein. So this is showing that main portal vein as it enters into the liver at the porta hepatis. So these are the borders of our liver that we could see here. This is our porta hepatis, where things enter and exit out of the liver. And we can see that main portal vein entering into the liver here. So this is bringing blood flow into the liver. This is now our sagittal view, or longitudinal view. We see our IVC and sagittal running up and down. And the superior mesenteric vein now is visualized emptying or connecting or coming into that main portal vein, or forming that main portal vein. So what goes in must come out. That's a golden rule for vascular. When we have blood flow going into something, blood flow ultimately has to exit something, exit that structure. So when we're talking about the liver, the drainage for the liver is going to be our hepatic veins. So we have 3 hepatic veins. We have a right, a middle, and a left hepatic vein. These veins will separate liver segments. So again, that's something we're going to learn a little bit later on, how it differentiates and divides the different segments of the liver. But just know that the blood flow in these vessels is now called hepatofugal. So it's flowing away from that liver. So remember, hepatopedal is towards, fugal is away or out of the liver, or away from the liver. The waveform within the hepatic veins has what's called a W shape to it. So it's actually almost like a triphasic waveform. It's very pulsatile in nature. And this has to do to having a lot of cardiac influence on that vessel itself. So the liver sits pretty high up. It's just below, or the diaphragm, sits right on top of that liver. So there really isn't that much distance to go for that blood flow to get to that right atrium of the heart. So we have some cardiac influence on this blood flow in the hepatic veins. So we'll be able to tell right away, patients, like we said, that are in congestive heart failure, we saw pulsatile flow within the iliacs, within the veins of the legs. Same thing here, we could see very pulsatile flow, which could be normal just due to that close proximity and influence of the heart. So here we can see hepatic vein anatomy, right, middle, and then left hepatic veins draining into the IVC. So all these kind of converge and join into the IVC along that superior aspect of the liver, just below the level of the diaphragm. So here you can see now we have a transverse view. So it kind of looks like a bunny. You might hear this referred to as like a bunny sign when you want to image the hepatic veins. So here we're in a transverse view. This is our IVC and transverse. And we can see the left hepatic vein, middle hepatic vein, and then this is a portion of the right hepatic vein, all coming together and draining into that inferior vena cava. So this is a normal hepatic Doppler waveform. So you could see, it is kind of triphasic in a way. It kind of goes above the baseline. So it's very pulsatile. So we don't actually, describe this, as biphasic, triphasic, monophasic, because it's a vein. We don't have, again, that influence of the heart, to dictate systole and diastole. So this doesn't have any sort of systolic or diastolic component to it. But because of that close proximity to the right atrium of the heart, we do have some of that influence of the cardiac influence on this waveform. So this has to do with the filling and emptying of the right atrium that we get this flow reversal. So contraction and expansion of that right atrium, some of that gets translated back into the hepatic veins, and we can pick that up on our Doppler waveform. So this is just a detailed diagram just showing, again, a lot of our anatomy vessels. All right, good practice for you guys. Name the vessels. Talking like you're here. I'll pretend like you're here. All right, Brian, number one. Just kidding. So number one, you guys should be able to recognize that right away. That's going to be our celiac artery, celiac trunk, celiac axis, all the same thing. So then branching off that celiac trunk, we have our splenic artery going out to the spleen, as well as our common hepatic artery going out towards that liver. On here, we don't actually visualize that left gastric, but if we go to number two now, so just remember, this is our aorta. So what's something coming off the aorta going lateral to the kidney? That's going to be your left renal artery. Number four over here. So this is the artery coming off anterior, just below the level of so just below the level of the celiac artery, but above the level of the renal arteries. This is our SMA. Number four, SMA. Number three is just pointing to the abdominal aorta. So that's just, your normal abdominal aorta. Number eight now. So this one is actually coming off of our inferior vena cava now. So this is coming off the inferior vena cava going out to the left kidney. This is going to be left renal vein. Number five. So number five shows a vessel coming off the aorta laterally, coursing posterior to that IVC, going out to the right kidney, right renal vein. Number seven, we said, was our common hepatic artery. Then you could see that common hepatic artery then branching into proper hepatic, and then the gastroduodenal artery. All right. That is the abdominal vasculature or peripheral vasculature. Now we're going to just talk a little bit about some of the peripheral vasculature, upper extremities and lower extremities. Just some general terminology. Arm typically refers to the upper extremity from the shoulder to the elbow, forearm, elbow to wrist, thigh, pretty explanatory, from hip to knee. Sometimes when they say leg, that can just refer to between the knee and the ankle. All right. So also important to know when you're trying to identify vessels is normal anatomical position or standard anatomical position if you go back to A&P. So standard anatomical position, when we want to discuss, whether things are medial or lateral, particularly when we're talking about vasculature, you have to position yourself with your hands or palms facing forward. So when you're talking about vessels being coursing along the lateral aspect or the medial aspect of the forearm, just always remember the patient's hands have to be facing forward when we're referring to medical anatomical position. So if my hands are facing forward, this is going to be lateral aspect of my forearm, and then medial aspect of my forearm. Again, lateral aspect, palm facing forward, medial aspects of my forearm. Same thing, upper arm, medial, lateral. All right, upper extremity arteries. So we have subclavian arteries, one on each side. Right subclavian is a branch off the innominate artery. Ends at the thoracic outlet. Left subclavian artery is a branch off the aortic arch itself. Draw our aortic arch on the right. The heart, aortic arch. Descending aorta. So this is thoracic aorta, heart, descending aorta, aortic arch, descending thoracic aorta. So this is innominate artery on the right. Innominate artery branches into our subclavian, and then right common carotid going up. So this is right subclavian, and then left subclavian, directly coming off that arch. So nice thing about arteries is they kind of, these guys, particularly the central arteries, they're just extensions of the same artery. Like we don't really have any branching yet, just they change names as you kind of cross state lines. So think about it as like a highway, just kind of changing its name as you cross over, you know, into another state. You're still driving down the same road, same pathway, you know, you haven't gotten off anywhere, you haven't detoured anywhere, no branches anywhere. You're just crossing state lines, and that road just happens to change to a different name. So, you know, it's like I-95 all of a sudden becomes, I don't know, Route 1, then becomes Route 13. I don't know Delaware, but like I know a little bit of Delaware, but anyway, so it's still the same pathway. So right subclavian, we're coming across, you know, the front of the chest. We're entering or exiting that thoracic outlet. That right subclavian will eventually become the axillary artery as it exits that thoracic outlet. This becomes axillary. So same thing, left subclavian coming out. We can have our thoracic outlet here. Then becomes the axillary artery. So if you think axilla, the armpit, that's where the axillary artery gets its name. We have the axillary artery. The axillary artery crosses along the inner aspects of the arm from the thoracic outlet to the teres major muscle. So once we get down into that proximal portion of that upper arm here, that's when that axillary artery again crosses another state line, that teres major muscle, and now becomes the brachial artery. So then brachial artery kind of coming down the arm. Do another state line. This is now brachial. Same thing. This is our teres major muscle. Getting into that upper arm now. And now this becomes brachial. So it's brachial artery. So really it's essentially, you know, same artery, just changing name as you're coursing through different areas. So brachial artery then will continue down the upper arm, and then just below the level of the antecubital fossa, or antecubital fossa where that bend in the elbow is, just below that, right in that proximal forearm, that brachial artery is then going to split and bifurcate. So just below the level of the elbow, it's now you're going to get your first split, your first detour or bifurcation or branch into the radial and the ulnar arteries. please excuse the crudeness of this drawing. So anyway, so that brachial arteries, again, just below the level of the antecubital fossa, just below that elbow. You then have branching of that into the radial and the ulnar arteries. So radial artery, if you think anatomical location now, courses along the lateral aspect or the outside of the forearms. So you can put, radial along that lateral, and ulnar along the medial aspect of the forearm. So this is down in the forearm now. So radial, lateral, ulnar, medial. Radial, ulnar. Going back to, I guess, God, what was it, high school for me or something like that. I don't know. One of my professors was always like, to remember, radial, ulnar, which is which. They always said PU, like, PU, something stinks. So pinky, ulnar. So if you're on your pinky side, that's the ulnar, PU. So if you kind of just remember that, pinky, ulnar, the ulnar is along that medial. If you just remember your normal anatomic position. The ulnar artery does have a branch called the interosseous artery, which kind of courses kind of in the middle of the two down the forearm as well. And then once we get into the hand, we have two palmar arches. So the deep palmar arch is a branch off of the radial artery, or an extension of that radial artery. So deep palmar arch for a radial artery extends, goes around, creates an arch in your hand. Superficial palmar arch is an extension of the distal portion of the ulnar artery. Again, kind of wraps around. So we're going to learn when we do Allen's tests, when we're specifically talking about the superficial and the deep palmar arches, and potentially harvesting the radial artery for use for bypass, the importance of the palmar arches and how they're actually connected to each other to kind of create almost like a fail-safe or collateral channel for blood flow to get around and feed and perfuse the hand and the digits, So if like one vessel becomes occluded or blocked, ideally, in a healthy patient, if they have what's called a complete palmar arch, those two superficial and deep palmar arches will be connected and be able to perfuse and adequately perfuse the entire hand if one of them becomes occluded, or if we needed to remove one of the vessels for bypass surgery for the patient's heart. So it's just showing the thoracic outlet with the subclavian artery and the subclavian vein coursing underneath that first, over that first rib. Anterior to that first rib and underneath the clavicle. And then we can also see over here this pectoralis minor muscle connecting and coursing anterior to that artery as well. So this is a nice schematic diagram showing, from the aortic arch, all your vessels on the left side here. So again, we said, it's just the vessel, changing names as it courses. It's more just anatomical diagrams showing your arteries. So this is good. So these are, when we're talking about peripheral flow in the upper extremities, So this blood flow isn't going to any sort of organs. It's just supplying our muscle beds. So these are going to be high resistant waveforms. So you can see obvious high resistant waveforms. So these are all normal, nice high resistant waveforms. You know, they have very tight spectral envelopes, you know, clean spectral windows. They're very triphasic. This one even looks like it has more triphasic, to be honest. But again, all these arteries, nice high resistant waveforms, nice sharp peaks, nice fast deceleration. So these are all nice, healthy, patent, normal peripheral artery waveforms. So these are what things should look like. So upper extremity arteries, there's also, I mean, we just talked about the main pathways, but just know that there exists lots of smaller branches that do come off of these main highways, these main pathways to perfuse different parts of the body as well. So typically on ultrasound, a lot of these vessels are, you know, really too small for us to ultimately image and visualize adequately, but just know that they do exist. So this showing an angiogram with contrast, just showing brachial artery coming down and then bifurcating and splitting into the ulnar and radial arteries. And then we could see that interosseous artery, I, kind of branching from that ulnar artery. So ulnar artery continuing down, and then the interosseous artery kind of in between here. This is just a picture, you know, showing the superficial and deep palmar arches as they come around. So we said radial artery was the extension of the deep palmar arch was an extension of that radial artery, and we can see it kind of looping around and also connects to that superficial palmar arch, or connects back to that distal portion of the ulnar and the superficial palmar arch. Just mentioning their occurrence for anatomical variants. So again, there could be also, you know, anatomical variants that do exist. So in this case, this patient had a very high origin for their radial artery. So in this case, they had brachial artery coming down and then just an ulnar artery in the forearm. And this radial artery connected somewhere higher up on that brachial artery. So it wasn't a normal, you know, nice bifurcation and split where we typically see it. So just remember that anatomical variants, you know, could exist. So here we see in the upper arm where that radial artery actually connects to the brachial, high up in that upper arm. And just realize there could be lots of little collateral channels and branches that could exist. Again, just naming the vessels for the upper extremity. This is, again, good practice for you guys. One, going to be subclavian or right subclavian specifically. 5, axillary artery. 3, brachial artery. 2, so we're along that lateral aspect of the arm. That's going to be our radial. 4, along the medial aspect. That's that ulnar. 9, the interosseous artery. So now we just kind of have to look a little closer here. 6. So 6 looks like this is the deep palmar arch, right? Yep. Extension of that. Yep. So 6 is going to be our deep palmar arch. 7, superficial palmar arch. I can't see this. Hold on. So lower extremities now. I'm getting hot. Only 83 in here. Lower extremity arteries now. So when we're talking about the lower extremities, so first branch off that abdominal aorta, we said was the common iliac arteries. So the common iliac arteries will bifurcate or branch into the internal iliacs and the external iliacs. So internal iliacs will go to supply the organs of the pelvis, whereas the external iliacs will continue on down to supply blood flow to the lower extremities, to the legs. The common femoral artery starts at the level of the inguinal ligament. That's just an important landmark to familiarize yourself with, because that'll often appear on boards and registries. I like to ask it. So we're drawing the leg. So up in the groin, we have our inguinal ligament, and I kind of use that as my landmark or my demarcation between common femoral artery and external iliac artery. So this is our inguinal ligament. So the artery above that inguinal ligament, so superior to that inguinal ligament, is our ECA, EIA. Been doing carotids all day. What am I writing here? Jesus Christ. External iliac artery, EIA. It's been a long day. It's been a long day. I apologize. EIA, external iliac artery. So above that level of that inguinal ligament is our external iliac artery, EIA. Once we cross over that inguinal ligament into the groin, into the proximal thigh, it then becomes our common femoral artery. So again, same thing like we had with the upper extremities. Same highway, you're just changing states. So you're just crossing over state lines, that state border. So in this case, that border is the inguinal ligament. So above the inguinal ligament is the external iliac artery. Below the level of that inguinal ligament is the common femoral artery. Common femoral artery will then split and branch. We have into the superficial femoral artery and then the profunda artery. So this is still relatively high up in the leg, in the area of the groin. So common femoral splits into SFA and profunda. SFA, profunda. So profunda is sometimes also called the deep femoral artery. So sometimes you'll see it abbreviated as DFA, deep femoral artery. SFA, superficial femoral artery. Sometimes you'll also only hear that referred to as FA, as femoral artery. We'll notice that particularly when we get into venous anatomy, you know, the reason why they dropped that superficial in front of the femoral artery and femoral vein. But, just know that this profunda or deep femoral artery can sometimes act as a collateral pathway if this SFA is occluded or obstructed. So SFA courses down the thigh. I'll draw a little knee here. So at at the level of the knee, that SFA becomes the popliteal artery. This is now popliteal. That popliteal artery then bifurcates into the anterior tibial artery and then the tibial peroneal trunk. So we have ATA, anterior tibial artery, and then tibial peroneal trunk, tibial peroneal. Sometimes you might hear that just referred to as the trunk. That tibial peroneal trunk further down in the calf will then split into your anterior tibial and peroneal arteries. So your PTA and then peroneal arteries. So just some anatomical facts for posterior tibial artery. It lies, the posterior tibial artery lies posterior to the medial malleolus and forms the medial and lateral plantar arteries. And it's located in the medial calf. Peroneal artery ends near the lateral malleolus. So medial malleolus is that inner ankle, the inside ankle. Peroneal artery will actually end near the lateral malleolus, so the outside ankle. The peroneal artery is near the posterior aspect of the fibula. That's also another landmark when we're scanning the calf that we can recognize, which is peroneal and which is the posterior tibial. Is just recognizing that fibula. So we'll get into that as well, but also to note that the anterior tibial artery, so that other branch, will course down and form the dorsalis pedis artery on the dorsum of the foot. So that's another important artery for perfusion when we're talking about blood flow getting down to that foot. So dorsalis pedis and posterior tibial artery, we're going to become very familiar with in the next few coming weeks, because those are going to be two vessels that we're going to be sampling and Dopplering and listening to here in the lab. We do have in the foot plantar arteries as well as digital arteries. So this is just a diagram showing some of the branching of those vessels. So there do exist some other branches that you might encounter and see, like lateral circumflex femoral, medial circumflex femoral. You might also see, lateral circumflex, medial circumflex. So this is that inguinal ligament I was referring to. So above that level of the inguinal ligament is our external iliac. Below the level of that inguinal ligament, before the bifurcation, is the common femoral. Then that common femoral splits, bifurcates into the SFA and the profunda. SFA is the one that we really follow and assess in ultrasound going down the leg. Becomes the popliteal behind the knee. That popliteal will then, this is coming from posterior now, so we're just looking, from the back of the knee, because this is the window that we're going to use to image it, because we can't scan through the bone, through the knee, so we have to come posterior to be able to see it. That popliteal then splits into anterior tibial and then a tibial peroneal trunk. That trunk then splits into your posterior tibial and peroneal. Also know that the SFA courses through something called the abductor canal. So that can oftentimes make it sometimes a little more difficult to image just because of the thickness of that abductor canal. And it also could potentially lead to the development of stenosis as a result of compression from that abductor canal. It's just some more detailed schematics showing some peripheral, showing the arterial vasculature as well as some additional branches. So again, just like the upper extremities, this is peripheral vasculature. So these aren't going to any sort of organs. This is just perfusing the muscles of the legs. So these are going to have nice, again, high resistant triphasic waveforms. So these are nice, pretty waveforms, nice tight envelopes, clean spectral windows, very little diastolic flow. This just shows some of those additional branches, that could potentially be present coming off the common femoral and the iliacs. Again, just some more angiograms showing some additional branch vessels. Again, the majorities are going to be way too small for us to really, assess adequately on ultrasound. So really, when you're doing these ultrasound examinations, these aren't, things that you're going to necessarily be interrogating. So this is just an oblique view from the foot. So just know that there are still some anatomical variants that can occur also in the lower extremity itself. This is just showing some collateral channels that have developed as a result of severe occlusion and stenosis. So in this case, the right common iliac artery was occluded. So you can see aorta, no contrast filling this right common iliac artery, a severe stenosis in the left external iliac artery. And just demonstrating, there are collateral channels that can open up in some of these other arteries and the results of, major occlusion. So this is good little practice again for you guys to kind of just quiz yourself, test yourself in terms of the segments of the arteries for the upper and lower extremities. Again, another diagram. Again, just, familiarize yourself with your anatomy. So really, I want you guys just, becoming real familiar, real comfortable with your anatomy, being able to label your vessels, know where you are, know what you're imaging. Because really, that's, half the battle. When you're first starting out an ultrasound, what am I imaging? What are these vessels? What am I looking at here? If you know where they're located, you'll be able to easier identify them. So now we're just going to do cerebral vascular and intracranial systems. So when we're talking cerebral vascular, this is the blood supply for our central nervous system. So central nervous system, the brain. So we're going to be talking about blood flow going up to the brain. So blood supply for our central nervous system. So the first branch that we have that's bringing blood flow to our central nervous system coming off that aortic arch is going to be our innominate artery. So just remember your aortic arch, the branches that as you're coming around that arch, that first branch is your innominate or brachiocephalic artery. This divides into the right common carotid and right subclavian artery. So right common carotid arteries going up the neck, cervical neck, and eventually bringing blood flow, to the brain via the internal carotid artery. We also have the right subclavian artery. So right subclavian artery, does bring blood flow out to the right arm. I'll do that way. I'm kind of looking at myself on the screen doing right. So right arm. But there is a branch off that right subclavian called the vertebral artery, which does bring blood flow up to the brain as well and supplies the posterior circulation. So that's why it is considered a blood supply for the cerebral central nervous system. The next branch off the aortic arch is our left common carotid artery. Same thing, bring blood flow up the left side of the neck to the brain via the left internal carotid artery. And then also we have that left subclavian artery, which is that third branch off the aortic arch. And off that left subclavian, we have the left vertebral artery, which then supplies blood flow to the posterior portion of the brain. So this is a diagram I kind of want you guys to just, become familiar with. So, start this off, become familiar with it. You have to recognize your branches and your vessels. So aortic arch, first branch, innominate or brachiocephalic. That brachiocephalic then splits and bifurcates into common carotid and right subclavian. Just give me 1 second. I'm going to pause real quick. It was God forcing me to take a little break. Again, you guys got to remind me because I will continue going on and on. So anyway, so this is an image, again, I want you guys to kind of become familiarize yourself with, showing the circulation or perfusion to the brain for blood supplies to the brain. So like I said, innominate, left common carotid, left subclavian, those are your three branches off the aortic arch. So brachiocephalic or innominate bifurcates or splits into right common carotid and then right subclavian. So that right common carotid will ultimately give rise to the right internal carotid artery. So this is right ICA, right internal carotid artery going to the brain, the anterior portion of the brain. This is the right external carotid artery, which supplies some of the muscles of the face. And then off of that right subclavian, we have the right vertebral artery, which goes up and perfuses the posterior aspect of the brain. So things like the cerebellum. Again, so we see left now common carotid artery splitting into external carotid and then internal carotid artery continuing up to the brain. So this is left internal carotid artery. Left subclavian with the first branch here being that left vertebral artery, again, bringing blood flow up to the brain. So that's why, those are all considered pathways for blood supply for the brain. So it's just an angiogram showing angiogram of the aortic arch and those branches. So these are the extracranial, so outside the cranium, outside the skull. We were able to visualize the carotid and the vertebral arteries. The common carotid artery courses posterior or posterolateral to the thyroid glands. So we were able to see that when we were scanning a little bit here in the lab. We were able to visualize, the thyroid gland on each other, as well as those, as well as the carotid arteries. It's typically deeper or posterior to the jugular vein. So remember, we saw that jugular vein kind of on top or more superficial, and then that common carotid artery below that. Typically, this common carotid artery, unless there's some sort of drastic, what am I saying? Brain's not working. Anatomical variant, there's not going to be any sort of branch for the common carotid artery. So a common carotid artery should be nice and straight, free of any sort of branches. And then the common carotid artery splits or bifurcates into the internal carotid artery and then the external carotid artery. Just prior to this bifurcation, there's an area of dilatation that's referred to as the carotid bulb. So this is just before that bifurcation, that split. And the reason this carotid bulb is important for us when we're talking about imaging, when we get into carotid duplex exams, is because this is going to be one of the most common sites for the development of plaque formation. So this is where a lot of those intracarotid plaques and stenoses are going to start developing and wind up with a thickening of those walls and narrowing of the vessel itself. So this is a nice, again, sagittal view. You guys might recognize now is our common carotid artery. This is a nice, clean, pretty picture for a carotid artery. So we can see that thin echogenic intimal layer, inner lining of that vessel wall. So this intimal layer is actually so thin that this is actually just a reflection of that wall itself. In between that echogenic line is our medial layer, which appears more hypoechoic, and then we have a thicker adventitious or outer layer that's more echogenic. So this is a nice image showing that carotid bifurcation. So that splitting of the artery into internal and external carotid arteries. So that's something that we're going to get used to being able to scan. So not everyone is going to have this nice, pretty tuning fork or split. So blood flow is going in this direction. So remember, we're in sagittal, our notches are pointed up cranial. So blood flow, so this is going to be our notch pointing up. So blood flow is coming up the carotid artery and then splitting into internal and external. Being able to differentiate which one's internal and external, I have to know, which side we're on, either right or left. And you'll be able to tell based on the course of that vessel, which one could be internal, versus which one could be external. But I always say, in the end of the day, you have to Doppler it, and listen to that vessel, to really ultimately be able to tell which one is which. Here are just some characteristics for the extracranial carotids. So that internal carotid artery, I'll say, typically is larger. Typically, it's more lateral than the external carotid artery. So if I kind of have my head turned to the side, as I'm coming up the neck, lateral, like if the patient's lying there, the internal carotid artery is going to be more posterior or more lateral. External carotid artery is going to be more medial or more anterior, because that external carotid artery is kind of perfusing the muscles of the face, whereas that internal carotid artery is kind of headed up more towards the brain itself. So you can use the vessel lie to try and help guide you. Vessel size, potentially. I've seen patients where they're both kind of pretty similar. I've even seen patients where the external appears more prominent. Something else that could possibly help you is the presence of branches. So the internal carotid artery, the ICA, does not have any sort of extracranial branches. So that ICA is just a straight shot up, into the actual cranium, into the skull, up to the brain. And that first branch of the ICA doesn't occur until it's actually intracranial. So you can actually see up here. So this is that internal carotid artery coming up. So we're actually in the brain itself, and that first branch being this ophthalmic artery. So this ophthalmic artery, which supplies perfusion to the eye, is your first branch for the internal carotid artery, that ICA. There's an area of that carotid artery which is intracranial that refers to the carotid siphon. So this is the area where the anterior cerebral artery and middle cerebral artery and the posterior communicating artery kind of all split and trifurcate. Or just before, I'm sorry, the splitting of those arteries. All right, so that's internal carotid artery. We have external carotid artery now. So this is outside of the cranium again for our ECA, or external carotid artery. So again, typically, we're going to put that in air quotes, is smaller, and it's going to be more medial or inward. It's oriented more anteriorly towards the face. Supplies blood to the neck, scalp, and face. And then this has multiple branches that we could see extracranial within the neck. So within the cervical neck, the ECA has multiple branches. Some of them are intracranial, some are extracranial. That first major branch is going to be the superior thyroid artery. So this is the first branch off that ECA. So this is critical. It's important because we can oftentimes see that first branch and we'll know right away, all right, I see a branch coming off this vessel, it's got to be ECA. So we can use that to potentially identify ECA versus ICA. So if we see that first branch or any branches coming off that ECA, we know with pretty much 100% certainty that that vessel is the external carotid artery. Some of the other additional branches for the ECA include the ascending pharyngeal, the lingual artery, then going to the tongue, occipital artery, going towards the back of the head, the occiput, facial artery, supplying some of the muscles of the face, the posterior auricular artery. So auricular, think of it kind of like behind the ear, auricle, maxillary artery, and then this superficial temporal artery, which is located up here on the temple. So the reason these two are highlighted is because we can use these to help also, really, like I said, help to identify and the presence or properly identify the external carotid artery. So the reason the superficial temporal artery is highlighted is because we can perform something while we're doing a carotid duplex, something called a temporal tap, where we can put pressure, oscillating pressure, and kind of tapping on that superficial temporal artery, and we can get reverberations seen when we're Dopplering that external carotid artery. So during the diastolic component of that waveform, we'll be able to see little spikes or little oscillations in that waveform from us putting pressure, that tapping pressure on that superficial temporal artery. Like I said, ultimately, the real way to, really ultimately differentiate between these two is to Doppler. So the Doppler characteristics are also going to be different between the two. So Doppler characteristics for our external carotid artery is going to be high resistance because it's, again, supplying a lot of the muscles of the face. It's a different vascular bed as opposed to the brain. So the brain needs continuous 100% forward flow of blood flow. So it's going to be a very low resistant waveform. Response to temporal tap. So what we said, well-perceived oscillations with that temporal tap. The internal carotid artery, poorly perceived to absent. So it's not something that we can really pick up. External carotid artery, visualization of branches. External carotid artery, this is going to be extremely super rare for internal carotid artery seeing any sort of branches. Also with our color pattern, so we said that ECA is high resistance. So we may have that momentary period where we see no flow within that vessel. So it could be a portion of diastole where, blood flow is either absent or retrograde. So we may get some momentary period where there is no blood flow within that ECA, whereas the ICA maintains that continuous forward flow. So there's always going to be color within that vessel. So this is our Doppler waveform, a nice healthy internal carotid artery Doppler waveform. So you could see nice, significant diastolic flow component. I wish they gave me all eyes on here to just kind of have you start recognizing, some of the RIs, and then this is external carotid artery Doppler waveform. So you could see the diastolic flow component. So if I measure, put my caliper here for end diastole, how far above that baseline that is in terms of our end diastolic velocities, whereas I'm putting my caliper here, I'm, right above that baseline. So there still is diastolic flow, just much, much less with our external carotid arteries. Also, to take note, ECAs typically come to a very sharp point. And they also have a very deep dicrotic notch. So this is that dicrotic notch we were talking about, separating systole and diastole. So ECAs have a deep dicrotic notch. Sometimes this will even drop below the baseline. You'll see a momentary flow reversal within that period. Whereas ICAs, you don't have any of that. And they have a much more gradual downslope. So this is fast up and fast down, creating that very sharp peaks. So here's visualization of that superior thyroid artery, that first branch off the ECA. So we know right away, here's our ICA, here's our ECA, because we visualize a branch coming off that vessel. Other vessels that we can image are going to be our vertebral artery. So this comprises the posterior circulation for our cerebral vascular system. So vertebral arteries are the first branch off either subclavian, supply the posterior part of the brain. So this is the medulla, the inferior surface of the cerebellum. The right and left vertebral arteries join at the level of the pons to form the basilar artery or basilar artery. So two vertebrals come together, form the basilar artery or basilar artery. This basilar artery eventually divides into the posterior cerebral arteries. So we'll see in a moment when we get into the circle of Willis. And this supplies, again, the entire pons, the superior and anterior aspect of the cerebellum now, and also form the part of the circle of Willis. So this shows the course of the vertebral artery in the cervical segment, so the extracranial part of the neck, our extracranial portion of it. So we can see it arising off the subclavian. So we get a segment here where we can visualize the vertebral artery, but then it starts passing through these little holes, these little foramen within the vertebrae of the spine. So that's how it actually gets its name, vertebral artery. So it's passing through these little holes within the vertebral column, these little foramen. And the fact that it passes through these areas of bone will cause us to get a picture that looks like this, actually. So we can see vertebral artery, and then that spinous processes, the spinous process that is passing through. The ultrasound cannot penetrate through bone. So bone for ultrasound is our enemy. We can't scan through bone. The sound waves just don't penetrate through. So we wind up with shadowing as a result of anything that's calcified like bone. When we learn a little bit more, gallstones, something like that, hard calcified, sound waves don't pass through, create an ultrasound artifact called posterior shadowing. So we get this shadowing from the processes of the spine. So we see artery, get the spine, the shadowing, so we can't see what's going on here. And then we see it again, the artery as it exits out of that spinous process and enters into that next area of the spine. So we only, Doppler in these segments that we're able to visualize. This is showing here that proximal segment before it actually gets into that area of the spine. So this is subclavian artery and then vertebral artery here. So vertebral artery, this is going to the brain. So we should expect to see a nice low resistant waveform, which we do here. So this is a nice normal healthy vertebral artery waveform. So this is going to look very similar to your ICA waveform, or it should look very similar to your ICA waveform. Again, some more practice. Again, I want you guys to just be very familiar with these diagrams, being able to label these diagrams. So 5, your ascending aorta, 2, descending aorta, 6, aortic arch. So those are your components: ascending aorta, aortic arch, descending thoracic aorta, ascending thoracic aorta, aortic arch, descending thoracic aorta. Innominate, 7. So if this is our innominate, 1 is going to be our common carotid arteries. So we have right common carotid, left common carotid. 3 is going to be your right vertebral. So 3 over here is again going to be vertebral arteries. So 3 vertebral arteries. 8. So if you think about your orientation, we said these were more medial. Those are going to be your external carotid arteries. This is going to be your internal carotid arteries, more lateral. All right, so intracranial. So now we're getting within the brain itself, inside the cranium. We have our circle of Willis. So we're going to learn the circle of Willis is pretty amazing, what it does and why it's there and the purpose of it, you know, being able to adequately perfuse all areas of the brain and the collateral channels that do exist within it. So it's a hexagonal arrangement of arteries composed of the anterior, middle, and posterior cerebral arteries, which are joined by the anterior and posterior communicating arteries. A vital collateral pathway. So this serves as a vital collateral pathways in instances of arterial occlusion and carotid or vertebral basilar disease. There are anatomical variants that do exist, but this is your normal anatomical appearance of the circle of Willis. So this is that hexagonal arrangement of these vessels. So you kind of have to look at this as kind of like a bird's eye view. So I'm a bird flying over a patient, looking down at the patient's skull, you know, the top of the head. And I'm looking down at the circle of Willis. So this is anterior. So over here, I can, like, if I want to, draw two eyeballs. So this is your ophthalmic artery that we were saying was that first branch of the internal carotid artery. So if you want to draw two eyeballs here, that, for me, that helps me to visualize, you know, what I'm looking at, looking down at this. So blood flow coming into the brain really has two main channels. There's two main pathways that are bringing blood flow into your brain. So it's via your internal carotid arteries on each side. So right internal carotid, left internal carotid, and your two vertebral arteries coming up the back, supplying the posterior aspect of your brain. So right vertebral, left vertebral. So the ICAs will come up and form that carotid siphon as it's going around that curve. And then you get branching of into the middle cerebral arteries, this MCA, and the anterior cerebral artery. So same thing on this side, ICA comes up, goes around the turn. This is that carotid siphon. And then you have branch into the ACA, the anterior cerebral artery, supplying the anterior aspect of the brain, the middle cerebral arteries supporting the lateral aspects of each side of our brain. Then first branch off that ICA is going to be that ophthalmic artery. And then we have the branches of the middle cerebral and anterior cerebral arteries. Posterior circulation, the two vertebral arteries come together, form that basilar artery. And then that basilar artery splits and bifurcates into the two posterior cerebral arteries. So these two circulatory circuits, posterior circulation and then anterior circulation, are connected by these posterior communicating arteries. So you have right and left posterior communicating arteries, which can connect both of these circulatory pathways or territories, as well as this anterior communicating artery. So here we have this small little vessel here, this anterior communicating artery. So this connects right side of the brain with the left side of the brain. So, and then these connect the front of the brain or posterior aspect of the brain with the anterior aspect of the brain. So if we have any issues, you know, in any of these vessels bringing blood flow up to the brain, these pathways, these communicating arteries, will help to create pathways where we can shunt blood to where it needs to go. So if I have, you know, in my neck, low down, a major blockage in this ICA, very little blood flow is getting through, or if it's completely occluded, nothing's coming up this way, I have this channel, this posterior communicating artery, where I could take blood from my vertebral, shunt it over, and then perfuse, you know, the anterior aspect of my brain and the lateral aspects of my brain from that vertebral artery, as well as use this anterior communicating artery and get blood from my contralateral or opposite ICA through coming across my anterior cerebral artery, crossing over, and then bringing blood flow to this side as well. So I can steal blood from the other side that doesn't have an issue, as well as that same side from the posterior circulation. So that's why these communicating channels and this arrangement, you know, is so amazing and so important. So if you guys, again, it's kind of a lot to digest, but if you have any questions about any of this information, any of this lecture, and then these topics, you know, please feel free to email me I'll be checking my emails, periodically over the weekend. I believe you guys all have my cell phone number as well. So if you need to text me, if you need any sort of immediate response, always, feel free to text me as well. Anyway, I wish you guys a safe, happy and healthy weekend. Heard it's gonna be fairly nice. And again, if you have any questions, I'll see you guys in lab on Friday, 8 a.m. So again, if you guys have any questions about anything, please feel free to ask. And I will see you guys all later. Thank you.